Hi, a very good morning to all of you. Next we will try to move. Yeah, in 4 minutes I will take introduction and then we will start up at 10 o'clock. So, you've done a very perfectly done cataract surgery, phacoemulsification, and the patient gains from 6 by 9 to 6 by 6, perfect crystal clear cornea, anterior chamber, everything is normal. 1 week down the line, the patient complains of some blurring of vision. 1 week down the line, the patient complains of some blurring of vision. And when you examine, now there are a little more cells in the anterior chamber, and we have a vision which is reduced to 6 by 12. I think we welcome Dr. Lalit Verma. You can take sir's presentation. So by 10 o'clock, we'll start the presentation. Yeah. Yeah. So this is the problem. So 6 by 12, vision is slightly reduced, media is slightly hazy. It's a little hazy from before. So this is the point of time where we need to take a decision as to, is this end off? Is this reaction? What do we have to do now? Do we have to hike up our steroids? Do we have to add antibiotics? Do you have to go for intravitreal injections? Do we have to do an early vitrectomy? So these are some of the pertinent questions that you have to take. And along with that, another basic problem which is there is, in your mind, how to communicate with the patient that this is indeed a possibility of endophthalmitis. You see, the diagnosis in this particular case is reasonably clear in that the vision improved postoperatively to 6 by 6, and then 1 week down the line, it is reducing with reaction. Reasonably clear in our mind. But not all cases are like this. Some cases in the first postoperative day, you may see a lot of reaction, and then you may see that there will be, you are wanting to differentiate between TAS on one hand and endophthalmitis on the other hand. So we have our esteemed panelists and our keynote speaker. Our keynote speaker needs no introduction. It is none other than Dr. Lalit Verma, the immediately past AIOS president, and he has done a lot of work on endophthalmitis, and he is the one person who is key person in distributing the endophthalmitis poster that we stick in all our operation theaters, having all the dosages and all those things correctly. TAS versus endophthalmitis is what sir will talk about, and how early we should treat. And then we will have a panel discussion, and our panel members include Dr. Saravanan, Dr. Rajesh, Dr. Asha, Dr. Prakash. So we are in for a very rich 1 hour session here. Yeah. Are we ready, sir? Yeah. Over to you, sir.
Good morning, everyone, and thanks KSOS and Dr. Gopal for having me here. Is the mouse not working here? Okay. Thanks once again. So, in this session where, Gopal has written enemy at the door, actually, these microorganisms are enemies. They are normally present in the conjunctive flora also. And therefore, a lot of preventive measures, have been advocated to kill these microorganisms so as to prevent the entry. And I personally believe wound construction is the one of the main thing which is very, very important. So it is one of the most dreaded, most feared, most serious, most devastating kind of complication which can happen, and mostly for no fault of the surgeon. Usual culprits could include, IV fluids or, anything which goes inside the eye. And as I said, if patient has, load inside the sac which has not been taken care of, it can cause. Why I call it a disaster is that if not managed in time, or if not managed properly, then it can lead to consequences like this. Believe me, time is of utmost importance, and a lot of times we used to get, not now. Now I think everybody has become wiser. A lot of times we used to get people on topical drops or maybe sometimes subcontinental injections. So phthisis is not a result today. Although cases are going down, but believe me, when a single case happens, this can be very, very stressful for the surgeon who operates. You see, surgeon who does not operate, nothing. He is in any case a very happy man. But if series of cases happen, it is a very, very maddening situation. So as I said, a lot of thrust has been laid on this pre-operative measures, which obviously include to rule out infections. And per-operatively, although betadine has level 1 evidence, but sterile instrumentation, good irrigating fluids, and I have deliberately underlined good wound construction because this I believe is one thing which is preventive against endophthalmitis. And whensoever wound is not good, suture whenever in doubt. Intracameral antibiotics have been increasingly being used nowadays because of very nice publication from Arvind Group by Harpriya. Lakhs and lakhs cases were done, and this got published in ophthalmology, and even American Academy adopted. But if preventive measures fail, then early diagnosis and prompt treatment is the answer. And once you diagnose, intravitreal antibiotics are the mainstay. And if they are done properly, injected early, and you are lucky that organs are sensitive, the results are reasonably good, provided you do it very fast. And you have to be lucky that organs are sensitive. Otherwise, you have to resort to vitrectomy or wait for culture sensitivity report. So key issues are always delay and delay. One delay is primarily because you may mistake as a TAS or not willing to accept that my case has developed endophthalmitis. A second delay is giving that appropriate treatment. So why should anybody differentiate TAS from endophthalmitis? Primarily because the pathogenesis of both is different and treatment is vastly different. In one, we load the patient with steroids. In other, we have to load the patient with antibiotics. So in TAS, we give steroids by all possible routes, but in Endoph, we have to give intravitreal antibiotics. In TAS, in any case, we do not go inside the eye most of the times. So this is one example which was being treated as inflammation because of these multiple keratic precipitates and this plaque on the posterior capsule, but it turned out to be a P. acne infection. This was one patient, a young lady who had undergone RK. She was referred for vitrectomy, but this turned out to be pure inflammation. So this lady was treated only with steroids. So I'll just exemplify by a couple of cases that why should you knock off the enemy at the door, which Gopal said. This is, unusual post-op reaction, good glow as you see here. This patient, I suspected TAS only and loaded this patient with steroids from all possible routes, but took photograph, every day, and fortunately, this patient did recover good vision, media became clearer. This was that young lady which I was referring to. She was operated for RK long time back, then phaco she underwent. But based on this whitish dropping, I thought this is purely inflammatory phenomena because of surgical insult and treated with steroids. And gradually, this took 2 weeks for this lady to recover. This was one of my patient, who developed hypopyon on day 1. This was a uncontrolled diabetic TRD patient who underwent a VR surgery, and operatively all vessels we found were sclerosed, and she underwent PPV. And first day, this was the picture. And notice that the IOP was 30. IOP in infection inflammatory generally not high. Generally not high is because of the cyclitis element is generally on the lower side, whereas in TAS it may be normal or it may be high also. So this patient had diffuse edema. Hypopyon can be present both in TAS as well as in. So this patient I monitor very, very closely because I was really concerned for this one-eyed patient. You see gradually, only on steroids, topical treatment, this patient gradually improved and hypopyon disappeared and fundus glow also returned to this position. This was one of the old, patient where this patient had a eventful surgery. You see the lenses in the anterior chamber, diffuse corneal edema, creatic precipitates, hypopion, lot of old KPs. This patient had not received any interval injection, and we were preparing this patient for IUL explantation and vitrectomy, but I gave it a try. I gave it intravitreal vancomycin, and fortunately, you see the end result was this. So this patient, responded to routine. So the moral of the story was that we analyzed a lot of these patients. Only 30% patients in this paper used to have intrathecal antibiotics as a treatment. Most of them used to have only subconjunctival injections and parenteral antibiotics. So moral is, if patient has not received intravitreal and you are preparing this patient for vitrectomy, no harm in trying intrathecal antibiotics. Results can be good sometimes, provided the organs are sensitive. This was another patient. You see, ultrasound showed full exudates in the vitreous cavity and descemet folds, PR, PL accurate. This patient again, I tried intravitreal antibiotics only, and fortunately, this patient also recovered. There are patches of iris atrophy from the previous surgical insult. This was one of my patient again. We had operated this patient for giant retinal tear. With silicone oil inside the eye, this patient had pretty good vision, 6/9 vision. And I remember the next day was a holiday, so I did go to see this patient on the Sunday morning. And what I saw on Sunday morning was this. So, point to be emphasized here is that there has to be no delay treatment. So I had to rung up my home that I will be late by a couple of hours because Sunday itself intrathecal vancomycin was given, and fortunately this was the result after a couple of weeks. Patient did recover back 6/9 vision. This is his pre-silicone oil removal. This is post-silicone oil removal and post-endophthalmitis also. Remember, this patient after SOR presented like this. So there was a disaster, and patient and his entire family was after my life. What happened? You told it's a trivial procedure, small procedure. It will not take much time, but anything can happen. So you have to be prepared. But moral of the story here is, irrespective of a holiday or a Diwali day or whatever it may be, you have to act very fast. And as Gopal said, do not panic, but act on the enemy. So this is the summary of this. I traced all the slides for him, the GRT patient. This was one lady who had already received multiple interval injections and presented to me with corneal abscess, and PL/PR was, doubtful. So this patient here also prompt treatment is required. It's not only intravitreal antibiotics that we say early, but even here also you cannot wait for vitrectomy for a long time. So we did a 3-port vitrectomy in this patient, and the usual ports we made, then made a stab incision to inject visco to protect the endothelium, then started teasing with the help of a bent 26K needle in the pupillary area to clear this fibrous membrane, because you can't enter inside the vitreous cavity without clearing the anterior chamber. The first and foremost task always is to clear the anterior chamber. And once this was done, the IUL also got mobilized in the process, and this was taken out. This IUL had one of the haptic which was missing, meaning thereby this patient had had some eventful surgery. This was the IUL which came out, and then we did a depression vitrectomy, sutured the wound. Ultimately, this patient, I had to put silicone oil. And this was the result after a couple of weeks. This was the corneal abscess which got converted into vascularized corneal opacity. This is silicone oil reflexes inside the eye. This was another patient who had had a cataract surgery done, and surgeon had put in air bubble there. In this patient, again, a prompt vitrectomy had to be done because patient had already received intravitreal and had a good result. So I'll just describe one of the series of endophthalmitis which I had, which I called a horror show. This was the first postoperative day. 3 silicone oil removals were done, a simple looking surgery. Often, you leave it for fellows to do. And believe me, all of them were VIPs, one doctor, one advocate, a third, I don't remember. But this was the end result. On the first post-operative day on a Saturday morning in a busy OPD, I do OPDs on Saturday, who were doing reasonably well, enjoying good vision after complex VR surgeries. And first day, sometimes you can be caught unaware. And especially, once you have a outpatient a department waiting, panic in the entire hospital, more than, what to do at that time. So best is, I isolated this patient, took them to the second floor of my center because there are a lot of panic there. So talk and talk. Took all the relatives, spoke to them that how this can happen. This can happen upon a trivial procedure. Also, anything, whenever there is a cut inside the eye, you can develop endophthalmitis. So, but I told them in case you cooperate, we will try to, cancel all the OPD, and first priority is to deal with all these patients of endophthalmitis. So fortunately, they were all, agreeing for that. We gave intraocular injection to all three of them on the same day, but monitored these patients, very, very closely. Fortunately for me, after day 9 or this thing, all of them fortunately improved. So moral of the story again here is knock the enemy at the door itself. So be patient. Patience is one thing, do not panic. Second is you can take opinion. What I did was I took out the register of the entire hospital, asked anybody else has developed this or not. Then talk with the patient as a relative and make them slightly cooperative, because if the patient does not cooperate, suppose these three had gone out somewhere, they could have maligned or did anything. But fortunately, since they agreed, then early immediate treatment, which is time-tested intraocular antibiotics, they did the job and they recovered with excellent vision, all three of them. So for me, management of endophthalmitis is just like a first aid. Treatment, whether intraocular antibiotics or vitrectomy, if not done immediately, can have detrimental, not only to function, but to structure also sometimes. So keywords always are, we suspect and react, but sometimes we do not act very fast. So early prompt treatment, whether antibiotics, vitrectomy or revitrectomy, can have gratifying results, or otherwise you can have detrimental result like this also. You see patient where the intervention has been delayed, you have extension from corneal abscess to scleral abscess and ultimately maybe phthisis bulbi. But early if you do it, prompt management, then all this smile can come back on the face of patient as well as on the face of doctor that you have saved these eyes from phthisis bulbi. So thank you very much for this opportunity given to me.
Thank you very much, sir, for that enlightening talk. So you showed a lot of pictures of endophthalmitis, sir. Can you please? Can you put in the next slides? So the next 38 minutes, we will go through a panel discussion. Yeah. Can you open it? Yeah, Gopal Pillai. Yeah, thanks. Yeah. So what sir was still, can I use my mouse? Yeah. Okay, so the situations can occur in three different timelines. One is day one. When you open the bandage itself, you are having a suspicion of an endophthalmitis. Number two, it's like significant improvement in vision, and then followed by decrease. And number three is good improvement of vision for 2 weeks, 3 weeks, 4 weeks, and then drop in vision. In the second and the third scenario, the diagnosis is not really so much of a problem. But in the first scenario, what sir showed between TAS or reaction versus endophthalmitis, we'll just just put in a word of how it will be differentiated. TAS, more of a, multiple, case in the same day, cornea white to white involvement, not so much conjunctival involvement, not so much pain, reaction may be there, but then it is not going to be yellow colored exudates, etc. And wound infiltrate won't be there. The PR will be accurate. The media, the vitreous, not so much hazy. So that would be the differentiation. Any other point that I have missed, sir? Yeah, pain. Pain in endophthalmitis vitrectomy study, it was said that about 25% of patients did not have pain. So presence or absence of pain is not, but if there is pain, yes, TAS can be ruled out. Yeah. Any other point in this? No, you can talk to the mic if you can. Is there one more mic there? How many mics are there?
See, TAS usually develops on day one, and if you are having a lid edema in association with all these symptoms, then it might be in favor of endophthalmitis. The TAS may not be having a lid edema. So lid edema is...
Yeah, to me also, lid edema, chemosis, if they are there, and pain, they three go in favor of endophthalmitis.
All right.
So these three ominous symptoms, signs,
Yeah.
lid edema, chemosis, and pain.
Yeah.
And matlab patient having a bad face that he does not see anything. Because as soon as the patient enters your chamber, you can make out that something is not good. Whereas if you have given treatment, then smile comes back. That's very good. So I think I agree with this that the presence of lid edema, chemosis help in differentiating from TAS.
Yeah. Yeah.
Then one more thing that how complicated the surgery was.
Yeah.
The surgeon will know. Some other cases with posterior synecdoche, non-dilating people where they have used the hooks and all this stuff may have some reaction next day. So the surgeon has to decide. Totally uneventful case next day morning, 2 millimeter hypopyon. We have to take it as endophthalmitis because it is better to diagnose endophthalmitis rather than denying it.
Yeah. Yeah.
One question you can ask always: how much time this surgery took?
Yeah.
Because if patient has been referred, if it is your own patient, it's okay. If a patient has come from outside, then you can ask how much time. If surgical time was more.
Yeah. So one thing is about history of previous the surgery which is done. Next thing was about symptomatology. Chemosis, lid edema, pain, these things. Now regarding visual acuity, in TAS we will not get PR inaccurate. If it is PR inaccurate, it is almost definitely an endophthalmitis to start with. You can give that mic to Ashad also. I mean, let all the mic to
This sort of heavy vision loss usually happens in hospital-acquired infections, with especially the gram-negative spectrum. But a lot of times, what we see is the gram-positive, or a lot of times the congenital commensals. There, the onset may be not in the first day, it may be later on. But the symptomatology will not be so spectacular like what we are describing right now. So, hospital-acquired infections, especially the gram-negative, will present very profusely on the first day or second day, whereas the other infections tend to a little bit later on with the lesser symptomatology.
That's a very important point. So in the first day, if we are having an endophthalmitis, you are possibly having a very virulent endophthalmitis. Very virulent organism having an endophthalmitis. The later, or the dose that went in was very, very high. That would also be the reason. So these are the two things that could be there. Now coming to clinical examination, like wound infiltrate, hypopyon. How much value do you give to hypopyon?
Usually give a lot of importance. Hypopyon especially, I feel not necessarily, but it's one more additive factor to say it's an infection. That's what I feel.
No, but
and exudates also I give a little bit more importance.
Exudates in the
anterior chamber, iris, wound, paracental spots, or the IOL bag.
Yeah. So one thing is, like Dr. Mahesh was telling about a very complicated surgery. After very complicated surgery in day one, if you have hypopyon, it is okay. It is normal. It's just WBCs. Whereas in an uncomplicated surgery, if you have hypopyon, then you have to look at it. But the other things, including a exudate at the paracentesis or on the IOL or around the iris, these are very, very important, I think.
And there is a phase of denial by the surgeon initially.
Yeah.
He thinks that I have not had any end of past few years. So this is not end of. Actually, it is better to consider reverse. This is an end of. Why it is not an end of? Then we will treat it
So
as end of.
always treat it earlier as end of would be better.
I will tell you the reason in some medical legal instances at the end.
Okay. 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 So hypopyon is also important. Vitreous haze usually will not be there in TAS. It will be significantly. If there are exudates, frank exudates, then we are looking at an endophthalmitis. Now there is an important caveat here, because right now with intravitreal injections there are a lot of reactions which are coming in, and some of these reactions will have vitritis or vitreous exudates, and we are observing them. So what do you think about it, sir? Because in the sense, we, after intravitreal injection, if there has to be some exudates, we should be thinking in terms of an endophthalmitis and planning an early vitrectomy, because the dosage directly went into the vitreous. But now instead of that, we are probably observing. What is your thought process about that?
The color of the exudates also gives a little bit of
All right.
clue actually.
Okay.
More yellowish is more infective, more whitish probably it's inflammatory. Again, these are all like not pathognomonic signs.
Okay.
We lean towards this side or that side depending upon the color and the size of the clumps also.
In the B scan, we are looking at the vitreous opacities, right?
Yeah.
Initially, you see there is some opacities. After the injection, next day it will be definitely more.
Yeah.
Because Vanco and all will precipitate inside.
Yeah.
So that time you have to look at the anterior segment whether there is any improvement in vision.
Okay.
Based on this vitreous, there will be definite
Okay.
worsening in ophthalmology.
B scan may be anechoic also, because B scan is dependent on clump formation. Otherwise, that spike may not come, either A or B scan. So differentiation sometimes may not be easy. After injection, the haze is a diffuse kind of haze, which is, you can see through that.
Yeah.
Whereas the end of, you will have some clumps of yellowish looking
Yeah.
or creamish looking
Yeah.
opacity.
Yeah. So the point in B scan is that B scan is not pathognomonic. Even in a normal patient who has an asteroid hyalosis or maybe a PVD, you may get a lot of problem there. Whereas in a patient who has endophthalmitis, sometimes you may not get a lot of echoes. So it's not pathognomonic, but a change in echo texture in an ultrasound when we are monitoring is a very important thing. Yeah, Saravanan.
So in a gram-negative infection, where the acute bombarded very severe infection,
Yeah.
you can get T sign even in the absence of significant vitreous opacities.
All right.
So I will be going to panophthalmitis, but if you look at the scan, it will be almost normal.
Yeah.
So as Sir was saying, until the clumps start forming, ultrasound will look more or less normal.
Yeah.
So sometimes if you put too much weight on USG, you may be misled actually.
Yeah. So that is again another point, because Thomas, can you join the panel? Sir has to leave. Yeah. Sir, you will be coming back?
Yeah.
Okay. Yeah. So one more important thing is like disc edema or choroidal thickness increase or even a frank T sign would not usually be seen in a TAS. So
RC
you're-
complex thickening also.
Pardon me?
Retinochoroidal complex
Retinochoroidal thickening also. Choroidal thickness will increase. Yeah. So these are some of the points in suspecting endophthalmitis and coming to a conclusion. All right. So this is what we wrote. In case of doubt, all right. So we have a doubt now, and should we give systemic steroids and wait for maybe 1 or 2 days, or hike up topical steroids, or should you directly go in and do an intravitreal injection? What do you think, Asha?
No, we should wait and see with the topical steroids, and maybe we can give or oral steroids also in a minimal dose. We may not need to give a higher dose of oral steroids. Maybe for 2 days we can watch if it is responding well, and if in a mild, definitely. When
All right.
we
All right. So it's like if the vision was 6/6 and it fell down to maybe 6/9 with some reaction, would you consider giving systemic steroids, or would you consider intravitreal injection? What is the panel's opinion? 6/6 to 6/9. So is there a cutoff below which, like 6/6 post-operative vision was there, it dropped down to 6/18? Would you still consider steroids?
No,
Yeah.
it depends because I think vision should not be the criteria, because beginning of endophthalmitis you may have good vision in these patients. So it is at that point of time you want to diagnose endophthalmitis rather than having after vision drop. So your index of suspicion should be high. It depends on other things, what we mentioned
So
earlier.
vision is not the only criteria, but obviously the vision, when it is reduced, it would mean that the media is more hazier, cornea may be more hazier, anterior chamber may have exudates, there may be a pupillary fibrin. All these things are the reason for 6/18. That is why I said 6/18. So I am not telling visual acuity in isolation.
What you're saying is true for most cases. But there are a few exceptions, like 90% what you're saying is true. But sometimes in fungus or in nocardia, you'll have a ball sitting somewhere, but the vision, central axis and the vitreous will be totally clear.
All right.
So what you say is 90% of cases it will be hold true. That's what probably he's trying to give some
No,
examples.
so if we have an index of doubt, how much would be the drop in vision or how much should be the media haziness to consider a straight away intravitreal injection in your
Anything
mind?
below 660, I would be a little bit more, almost always go for a.
No, I'm talking about a cataract case in which initial vision is 6/6
Again,
and
the
it dropped down.
His history-wise, everything was okay, or the patient got back 6/6, and then he's coming back with a 660 drop, and I can attribute that opacity, the vision loss to the vitreous. If only anterior chamber is there, I'll rely on the ultrasound also.
All right, that would be a point. So
vitreous
if only anterior segment involvement is there, then I mean, even if there is a pupillary fibrin, but then there is a small problem.
Yes.
The problem is that the pupillary fibrin was not there in day 1, and now in day 7 it is occurring, which should not occur in a cataract surgery. We know that in retinal surgery, it's like day 3 is the maximum, day 3 or day 4 is the maximum inflammation. But in cataract surgery, day 1 is the maximum inflammation.
This can sometimes happen in SICS PMMA IOLs
Okay.
because of the material induced inflammation.
All right.
Later on, after 3 weeks, it used to happen.
Okay.
So again, you have to take everything with the multiple factors are involved. But if an unfoldable case with the totally got 6/6 in the immediate post-op, then you will be leaning towards infection.
Okay.
actually.
So,
And the type of cells also give a clue.
Yeah.
The small cells usually we see in other forms of inflammation, whereas in endophthalmitis we see the large white cells. If you see that kind of cells, always have your high index of suspicion. This is going to be an endophthalmitis.
I see. I mean, why you are telling
So
me
that is because macrophages, I mean, those are organism eaten macrophages. They tend to be larger on slit lamp examination. The large cell, either it is a lens eat, either they when they eat lens or when they eat the organism, they become larger.
I
So
also
if you see
feel
the
like
large cells, then always have a high index of
I
suspicion.
have also noticed such incidences often because we can see thick and large floating cells than smaller cells we usually see.
Small fine cells you see in uveitis, normal forms of uveitis. Also, when once you have endophthalmitis and when it is responding, you can see the same change in cells. The larger cells tend to become smaller cells initially before the number of cells decreasing.
About
Just
steroid,
make sure patient is putting the drops. Sometimes he is coming to you after 2 weeks. 2 days before they have, the drops are over, they will think, okay, after coming here, I will buy.
yeah. So when would the panel decide that we are going to have intravitreal injections? Thomas, what is your take on it?
You mean on the first day or?
No, whenever you are clear in your diagnosis of endophthalmitis at whatever time, and you decide, okay, I am going to give injections.
As early as possible. When the patient reports with endophthalmitis and you are almost more than 80% sure that this is an end of, straight away you'll get a tap and inject.
All right. So tap without injection you will never do.
Tap without injection. I'll
So
never
in
give.
the sense,
Anyway, you're going
we are
in,
going in, we will give antibiotics. All right. So that's very clear. Yeah. Any difference?
I will do injection. If when I see the endophthalmitis, I will first ask, do I need to do a vitrectomy now? If I don't have to do a vitrectomy, I will give injection. That
All
I
right.
am coming from the
Okay,
other
so
end.
then I will reframe the question in such a way.
Yeah.
So if it is an endophthalmy, you have made a diagnosis of endoph based on all these things, right from symptoms, right from PR inaccuracy, right from exudates in the AC, exudates in the vitreous, ultrasound signs, all these we have made a diagnosis of endophthalmitis. What would be your, endophthalmitis vitrectomy study, which is fairly old? They told us that, vitrectomy is basically going to be done when vision is less than 1 meter counting finger. Now, what would be our indications of vitrectomy currently?
Forget about the vision.
That is
You see inside, there are echoes, hypoepion, exudates, and vision that vitreous is involved. Do vitrectomy.
Currently, EVS does
Currently,
not
it is
hold
the reverse
true.
from the other side.
All right.
So if I see that the vitreous involvement either with the visual confirmation or with ultrasound confirmation, if I can say that the vitreous is involved, immediate vitrectomy. Not just tap. I will go for immediate vitrectomy. If it's only a very mild vitreous involvement with the clinical suspicion of endophthalmitis, I'll go for only tap. Otherwise, I'll directly go for core vitrectomy.
No, the
That is-
type
that
of
means
no. Let me make it a little. I mean, it's becoming a little different now. For the diagnosis of endophthalmitis, we should have vitreous involvement. Okay, Endophthalmitis is
Intensity,
defined with vitreous involvement.
intensity
So
of
you are, yeah. So what is that intensity? How much will the vision reduce because of that vitreous haze? That is your,
That's what I sold
cutoff.
660. That was my cutoff. I think.
Your cutoff is 6/60. Mahesh,
Mine, actually, I will see the fundus.
Yeah.
If you can see the disc vessels and it is only mild inflammation,
Okay, so
I will give injection and
All
not
right.
vitrectomy.
so if you are
So
able
I
to
will
see
not
the
be
disc
rely on
and
the-
vessels, you will still
Disc
give
and
it.
vessels reasonably well.
Yeah.
Even that vitrectomy, I know I have to do a vitrectomy, but the moment I see the patient, I post it for an injection because for an injection, I need just half an hour for the drug to go in. For vitrectomy, I have to post the case. Maybe I'll take 2 or 3
All
hours
right.
to get it
So
done.
there are logistic issues
Yeah.
for
Ah,
vitrectomy.
immediately I'll inject.
I will give an opposite to this
In
thing.
case our theatre is already closed, they come at 6:37. Then we'll give only injection. But if the theatre is open, I'll do the surgery.
So logistically, if we have long duration for vitrectomy or your center do not have a vitrectomy facility and you have to send that patient somewhere else for a vitrectomy, at least try to give an intravitreal injection. That's the first point. Because there was a large study which showed that the contact time between reporting of the patient with endophthalmitis to injection, that was one of the most important predicting factor for the final visual acuity. Earlier you give the injection, the better it is for the patient. All right. So,
One more thing, Gopal. Regarding, I think we were discussing about vitrectomy versus injection. Yeah, so one thing, the moment I see an endophthalmitis, I try to make an etiological diagnosis at that point of time itself. What is the cause? If it is, as Dr. Saran was telling, a gram-negative organism, there will be a lot of toxins. And so intravitreal injection is not going to address, it's only going to address the organism. The toxin part is not. So if I suspect this is a gram-negative from all clinical findings, history, everything, if I have a feeling this is gram-negative, it's aggressive, then earlier it doesn't depend on the vision. So I go in.
That brings us to a very important thing. Like, for example, if you're suspecting virulence, in the sense that early endophthalmitis, or very massively severe endophthalmitis, then you are suspecting gram-negative and you're going in faster. Whereas if the patient comes after 3 weeks or 4 weeks with mild inflammation which is slowly increasing, then your index for moving into vitrectomy may be slightly lower. Is that okay for all? Okay. That's fine. Now we have decided, so vitrectomy, our decision was if there is significant decrease of vision less than 6/60 or the disc and macula, disc and vessels are not very clearly seen, then we will do vitrectomy. Till that point of time, we will be doing intravitreal. So what is your first choice of intravitreal injection, Rajesh?
No, it's always vancomycin and ceftazidime in the first instance.
Okay.
But
Will you not use meropenem, which is much better? Why you not use meropenem?
why? Because most of the patients can respond to vancomycin and ceftazidime. Why should you go for the last resort as the
No,
last
because
resort?
moxifloxacin is getting used intracamerally for all 100% of the cataract patients, and that is a very, very advanced drug.
Meropenem I reserve for infections which are not responding.
All right.
Piperacillin,
Piperacillin.
I don't give usually unless it's very severe.
No. So what is your first choice?
Cluster means first choice always ceftazidime only. Cluster means first choice always piperacillin. If it's a cluster.
More than one piperacillin.
More than one means?
Cluster,
More than one
cluster.
case. Cluster.
Okay.
Cluster means always piperacillin.
And
If
early,
it is a
very
single
early,
case,
second day, third
single
day,
case
it is
always
piperacillin.
ceftazidime.
All right. So if it is a cluster endophthalmitis, you will all move to piperacillin. Piperacillin tazobactam or piperacillin alone.
It's only piperacillin.
Piperacillin tazobactam and anything. That's all. These two.
No, plus vanco.
Plus vanco. Whereas if it is a single case, you will all move to vancomycin and ceftazidime. Vancomycin is 1 milligram in 0.01 ml and ceftazidime is 225 microgram in 0.1 ml. All right. You always use amikacin. Any reason particularly?
I always feel that in my cases, amikacin, initially I used a couple of ceftazidime, but amikacin gives a better response.
Okay.
And I have not seen, I just seen
Macular
one
infarction.
case of macular toxicity all these years.
Yeah. Okay. I also had one case of macular infarction. One case, yeah. But amikacin, I think, is more stronger than ceftazidime, definitely. But because of that chance of macular infarction, generally I don't use. But it is okay. I mean, it's a.
If it is Pseudomonas,
It's better.
it's gram-negative. I think amikacin is
Amikacin
the
is
best,
superior.
Best,
amikacin is
best drug.
superior to. But now with piperacillin tazobactam, that is much superior to amikacin. All right. Okay, so that's now suspect. When will you suspect fungal endophthalmitis? Ashad, Do you have any thoughts on that?
2 weeks post-op cataract surgery with a mild inflammation starting, gradually catching up. A large KPs, and we can see those fungal balls and infiltrates.
Yeah,
in the
fungal
retina
balls and
part of the lens.
hypopyon will be
Minimal
fixed.
and thick, small.
Yeah. And there may be satellite lesions on the retina, etc. So then we will think about fungal endophthalmitis. So in fungal endophthalmitis, would you consider giving antifungals intravitreally, or would you consider doing an early vitrectomy? What is the panel's opinion on that?
So again, it depends upon the vitreous involvement. If the vitreous involvement is very minimal, I would just not do just intravitreal. My choice usually is voriconazole injection.
Okay.
But if it is significant, or even sometimes if the antechamber balls are too much, I'll usually go for a bag removal, IOL removal with anti-vitrectomy.
Okay. So in a confirmed fungal endophthalmitis only, you will go for bag removal, IOL removal, or in a suspicion of fungal endophthalmitis, will you go for that?
No.
Okay. All right. So
All these patients have an
give
iris
a
has to be
fluconazole
carefully
oral
seen. Many
also.
times the balls are behind the iris,
Behind the
which you may miss clinically.
So maybe a UBM or an anterior
Even
segment
if
OCT
you
can give us a
suspect
lot
anything.
of information on that. All right. Asha, you were telling something?
We have to add oral fluconazole also. Along with
Definitely, yeah.
Oral fluconazole. All right.
Sometimes, especially in endogenous fungal infections, oral fluconazole itself can clear the issue.
We add for even post-op, we regularly add oral.
So systemic antifungal is oral fluconazole. Intravitreal antifungal, generally we will use voriconazole. Amphotericin, are you reserving amphotericin for some particular thing? Like Candida is more amenable to amphotericin B, right? So, okay. All right. So moving on to AC tap. Is there any role for AC tap? We will see when we are going in, generally we will do a vitreous tap. But one of the common mistakes that people do is they will use a 26 gauge needle to take out the vitreous, which it will never come. So if you're using an AC, when you're doing an AC tap, generally do with a 23 gauge or a 22 gauge syringe to take out. And don't use 5 ml or 10 ml syringes. Use 2 cc syringe and apply slowly suction to see if it is coming out. If you pull more, there is a lot of vitreous which will come out, which may increase the traction and cause a retinal detachment later. So taking a vitreous tap that way is to be important. Any other points there?
The needle can be moved in and out also. You may encounter a pocket where vitreous is liquefied. From there, you will easily get the fluid.
Yeah. And even if you don't get, you put the needle directly onto the culture medium. Direct plating is often more rewarding. Usually, in many centers, it's about 60 to 70% is the yield in an endophthalmitis. Sometimes in some of the other centers who are not regularly doing it, the yield may be even as low as 30 to 40% only. So even if you are putting the needle and giving, it will be all right. All right. So generally, AC tap is not very useful. Are anybody of you using multi PCR for that syndrome based diagnostic kit for endophthalmitis, or only culture and sensitivity?
We are routinely using PCR also. For especially in-house cases, we always do PCR because it's very important we know what the etiology is so that we can prevent it in future.
So he's asking the estate PCR or the routine?
No, we are going for any PCR is good, but when we are going routinely for that package, the iGenetics thing, which endophthalmitis panel.
Yeah,
So it
excite
will
on type
get
of thing.
thing. So we ask for a pan-fungal and eubacterial also along with it because that package does not include that.
So that is a very selfish interest because you want to know what is the organism that you are growing in your hospital. That is why you are doing it, but you are not regularly doing it for hospitals from which Endoff is getting referred to you.
The referral doctor gets very unhappy if I tell you have to spend another 15,000 for the panel. So that is the biggest problem.
If it is a cluster, it is better to isolate what is happening. One case is enough. No,
All right. So let's move on.
Usually, I think PCR is more useful when the organism is very slow growing kind of thing. So, Papillania, bacterium, acne, fungus, then that is
acne, fungus, these cases.
So, most of the time, I use it only for chronic kind of endophthalmitis.
Okay. So we talked about aspiration with 23 gauge needle. Same needle can be used for injections, or maybe you can change it. Glass syringe or plastic. Now nobody uses glass syringe. Everybody uses plastic syringes. 1 ml, 2 ml syringe, 5 cc. Generally use a 1 ml syringe. Location of injection. What is your preferred location of injection? You can start from Thomas. If you are doing an intravitreal injection, what is your location?
I'm a right-hander.
Yeah.
Left eye supranasal, right eye supratemporal.
So it's superior. Yeah.
Superior.
What about you?
For me, whichever the patient decides, which is if the patient looks down, I give superior.
Okay.
If the patient-
All right. Patient decides. Okay.
Same
Thomas,
thing, same thing.
Rajesh. Patient
I don't have a choice. Whichever I look
Whichever place the patient shows you, you will give. Yeah, yeah.
Avoid the area of that tunnel or whatever.
Okay.
Anywhere you can give.
All right. So it's not very important. All right.
I think for a cataract surgeon, you have to tell which area to give.
Okay.
We are all-
Ashad, any particular?
Supratemporal only usually.
Supratemporal.
And I prefer to give.
No. Why would Thomas and Ashad would like to give superior injections?
Convenience, our convenience only.
Okay. All right. Okay.
I think we should
No,
not
but when the patient strains, because this is topical and the patient has pain, and when the patient strains, there's going to be a Bell's phenomenon which takes a patient's eye up. So your convenience becomes a little difficult. Okay. So you block. So how many of you block while you are
Even
doing-
I prefer block because
The
it's very
reason
painful.
is,
The
first time, initially we are doing without block, but what happens is when you have to give multiple injections, especially in severe virulent organisms,
Yeah.
every 2-3 days you'll have to keep re-injecting.
So you'll give a subtenon block only, right?
Yeah, it is unlike
Everybody will
our-
give a subtenon block only.
It becomes a
Yeah.
severe mental trauma for the patient. They'll say, just send me home.
Yeah,
I'm
the
not
inflamed
accepting."
eyes are very painful.
Yeah.
So it's not
so
like
one of
our
the problem that you have
routine
to tell the patient is subtenon blocks may bleed because in the end of it's already a lot inflamed, so there may be a lot of bleeding coming in. All right. Any position for the patient after the injection is over? So lying flat or sitting
Giving
up?
amikacin, avoid.
Yeah, that is the time when this. I mean, amikacin is there. Then
Yeah.
generally try to position the
Position
patient.
the-
Yeah. Okay. Fine. Vitrectomy. So we decided on when to opt for vitrectomy. We already had a discussion there. We would do a vitrectomy when vision is like 6/60, or if the media is hazy that we are not able to see the disc or retinal vessels clearly, or if there is ultrasound evidence of significant choroidal thickness, etc., etc. So that will be the small gauge or 20 gauge. Any preference? Now I think everybody will move to 20 gauge, 23 gauge. All right. 23, 25, 27. Okay. Any preference on that? Whichever you get. Rajesh, quick answer.
23.
23. Any particular?
25. I'm using currently 25.
All right, but smaller incisions. What I see whenever the end off is more severe, there's going to be a lot of ciliary body edema. Probably there will be some migration of ciliary body. There may be cyclitic membrane which is developing there, and there is a chance that the infusion is suprachoroidal or subretinal. So that needs to be very clearly, and especially in smaller gauge, what happens is that the exudates may block the infusion cannula and can cause problems. That is why I usually consider 23 gauge for endophthalmitis.
Yeah. And if the you can't visualize it to make 6 millimeter cannula, put the 6 millimeter cannula. As simple as that. If you can't see the tip of the cannula,
Okay. Okay, now the next question is, are we going to do a core vitrectomy like in EVS, or are we going to do a complete vitrectomy with PVD induction and cleaning of the whole surface? What do you think?
It depends on the media clarity.
All
If
right.
the media is good, nicely can make the media clear by scraping. Sometimes you won't do the scraping of the epithelium also. Remove all FM from the anterior chamber. If there's any PC exudates, cut the central PC. If you can make it clear, as close and complete vitrectomy as possible. In case because of corneal edema, DM folds, whatever reason I'm not able to visualize, then I tend to finish only the core.
Also,
absolutely.
if the patient has a lot of retinitis,
agattu boyal, finish and come out, if possible.
Okay.
So that is the thing. Why should you leave the vitreous? If you can see everything, finish it off.
So visibility is the key here.
Visibility is
Thomas.
the key. When you do damage, when you think that you are going to do damage, stop it.
Yeah.
Again, induce a PVD and complete the vitrectomy, but don't go into the base and do a shaving and all that.
Yeah.
Just leave it.
Yeah, 10 minutes left. Oh, 10 minutes is left? I thought only 8 minutes were left. Oh, thank you very much. Yeah.
We got 2 minutes extra.
Yeah. Would you give, So, would you give intravitreal antibiotic after the vitrectomy is over, and at what dose will we give?
Right now, the first sitting I'm giving full dose only, but some people will tend to give half dose also. It's up to them actually. First sitting, always I try to give full dose.
Okay. So, I also give full dose.
When I full dose.
Yeah. Now, next thing is, would you consider? Yeah.
No, if you do,
Yeah. Now the next thing is, during the vitrectomy, would you consider explanting the IOL in the first sitting?
Definitely not. Definitely not.
Okay. So it is all for media clarity. If the IOL is creating a lot of problems in,
or confirmed fungal.
yeah,
Confirmed fungal and confirmed nocardia. In our hospital, you get a lot of nocardia. Nocardia and fungus, if it's already confirmed from previous step, I would try to remove.
all right. So now the next thing is, are we giving an intravitreal steroids during vitrectomy, or for the matter injection? During injection or vitrectomy, are we going to give intravitreal steroids?
I usually don't give it in the first sitting, but sometimes if it's not a very severe sort of fulminant infection, sometimes I combine steroids, decadron also, dexamethasone. But sometimes when you have seen some improvement, to make it faster, in the second or third injection, I'll add dexamethasone.
Exactly, same.
So
First
culture
injection,
and sensitivity decides, and we rule out fungus, and then in subsequent places, generally we should give decadron only, because decadron is short acting. Triamcinolone is going to be staying there for a long period of time, and if you are having a problem, then you are having a major problem. We have to again go in for vitrectomy.
But in very bad cases, I think like Pseudomonas,
Okay.
sometimes tricot helps after, at least during vitrectomy, putting
Okay.
tricot or leaving little tricot behind helps. To avoid that.
For
Because the
staining the
problem
vitreous
is,
or for the proper-
during staining and even leave little behind it actually helps. Because the problem with the gram negative, especially Pseudomonas, is organism, everything goes, inflammation never stops. The inflammation keeps on continuing, the chain inflammatory cascade keeps on continuing. So it helps actually. So this, I think.
So
there's
it
a
is
paper
important
from
that we
LVP
know
also.
that not only infection, but inflammation also kills the eye. So we have to adequately treat the infection and also optimally treat the inflammation. All right.
Intravitreal corticosteroids never for me. I always pump the patient with systemic steroids.
Okay. You give systemic steroids, which can be stopped anytime. Now, the next question. When will you use silicone oil in a case of post-operative endophthalmitis? Are you using silicone oil or not? If yes, when will you use it?
only if there is RD and you can complete a vitrectomy.
For me, any revitrectomy, if I am going, I have to go back in once more for any reason, I would prefer to put oil at that sitting.
I also did only when there's a tear, intraoperative tear or RD. But in our center, in Madurai center, that they have a protocol that any gram negative or any cluster, they directly put oil, because they feel that because usually in gram negative, you have sort of a lot of retinitis, and the post vitrectomy tears risk is very, very high. So there they have a protocol that all clusters and all gram negative, proven gram negative, they directly go for vitrectomy with oil. But
There are pros and cons.
Yeah,
for
there
all.
are pros and cons for both. I generally tend to be a little more in favor of putting a silicone oil and then later on removing it after some time, after maybe 2 months. All right.
If it is a vitrectomized post-op endophthalmitis, we can consider, like Sir has told some cases, no? Post-vitrectomy gas, some endophthalmitis.
Sir believes that silicone has got a very major role in controlling the infection. He is very prone silicone oil, Lalit sir especially.
Yeah. And many of the post retinal surgery inflammation, the choroidal detachment, maybe a retinal detachment. See, in a post vitrectomized endophthalmitis, if there is a retinal detachment post operatively, the results are very poor. All that can be avoided with a silicone oil. It's a little prophylactic anyway. All right, pros and cons are there. Any other point?
2 points you have to discuss. One is post-injection endophthalmitis and medico-legal aspects of endophthalmitis.
Yeah, before that, more important thing
Before that
would
one-
be to communicate to the patient. As a primary care ophthalmologist who is having an endophthalmitis, how are we going to communicate to the patient? And secondly, as a referring, vitreoretinal surgeon, how are you going to communicate to the patient so that we are shielding that primary ophthalmologist as well? That's an important thing. Yeah. Prakash, Thomas.
There is an anubadha or inside
So you will
the eye.
use technical terms
Yeah.
to floor the
Yeah.
patient.
There is an anubadha inside the eye.
Yeah.
It is.
I will
it is
say
something
near
which-
cut.
Yeah.
Use it profusely.
It is something which
near-
has to be taken very seriously.
Yeah.
And so we should not delay treatment. We'll start treatment expecting that you'll get a good results. Let us hope for the best.
Yeah. Tony sir also used one language. നമുക്കൊന്ന് ക്ലീൻ ചെയ്യണം. Cleaning.
Anything is cleaning.
Other actually cleaning, washing, and all terms, patient may think that you are not even going to take him to the theater.
തിയേറ്ററിൽ കൊണ്ടുപോയിട്ട് ക്ലീൻ ചെയ്യണം. നമുക്ക് ക്ലീൻ ചെയ്താൽ ഇത് ശരിയാക്കാം.
ഇഞ്ചക്ഷൻ ഒന്നും ഇല്ല എന്നൊക്കെ വിചാരിക്കും.
No,
Yeah, because that's a very important thing actually.
I feel that you should tell the fact to the patient, but don't create panic. So what I always tell the patient is that you create a wound during the surgery, and there are certain organisms in the eye which usually goes inside. We give medications, but most of the time it works. But some patients, these organisms have resistance to the medication that we
Yeah,
have
it's the
given.
same thing,
So-
technological jargon.
so-
Because instead of
that
the
is-
word infection, you will say microbiological organisms which are common
can-
cells there will go inside. So all those terminology you will use. Very good.
No, and Anubada,
Anubada.
again, the patient will ask you where you got it from. You can always say, we live in India, there is a lot of organisms
Either
flying
that-
around in the atmosphere.
Or the patient will come to you to say that I had cough, or that my wife did not wash her hands while applying the drops.
All that you
All that you should,
Only thing
all
that-
that history I had to take.
That you have to document also.
And you have to document also. Yeah.
Why
Now the last 3 minutes, I think I will give to Mahesh, because he has compiled a series of cases of endophthalmitis, about 70 cases, which the doctor has been put into the legal system, and he has done a meta-analysis of those legal cases. 3 minutes, Mahesh.
Okay. I mean, regarding communication, as Thomas says, me, a doctor, and the patient are fighting against the endophthalmitis. Okay, not that we are against the patient. We are in same set. Patient is with us, so we have to take him confidence, and then anyway, legal aspects. I compiled 45 cases of endophthalmitis, Supreme Court and High Court verdicts. And actually, let me give you the good news is that 98% is in favor of doctors. 98% of cases where the district and state consumer courts punished the doctor, it was nullified by the Supreme Court. So only thing that you need to do is systematic, proper treatment. Outcome is very difficult to predict because it can be a rare organism and you will lose the eye at the end. So everything, it's a non-complication. Supreme Court has given repeatedly in the many cases. One case was the Lalit Verma sir has managed. That is also there in detail. It is there. That was the doctor was not punished actually. So document everything and just do it properly. There was a case yesterday I showed. There was a delay of sending the patient for 3 or 4 days to the vitreoretinal surgeon and vitrectomy. That only point, everything was done. Actually, patient had an endo in Calicut, then came to Cochin, then went to Shankar Nethralaya. Everything was done, but there was a delay between the first and the vitrectomy, the referral. So that was the only point, and 2 lakhs was given to the patient. So these are few things. Document everything. Diabetes control is another thing. At least there are now a lot of cataract surgeons. I don't even check blood sugar. That is not possible. You at least document blood sugar is okay. This is fine. I'm not going to discuss what is the normal blood sugar level and all, but at least document everything. And then if there is an end-off, take it as end-off and tell the patient and start immediately with the intravitreal injection and then immediate prompt referral and management. Nothing will happen. Document everything. So this is my 98% is in favor of doctors. There are cases which went against the doctor. 1 for delay in referring, 2 not doing ultrasound, 3 not providing the sterilization records of the theater. You have to keep your theater OT sterilization registers and all. If you show the code that I have done all these cases, all these procedures to prevent infection, these are few things that records if you have, nothing will happen.
Thank you very much, Mahesh. And as you know, the diagnosis and management of endophthalmitis is rather subjective, but the principles are the same. There may be some individual variations. I thank you very much, all of you, dear panelists, for having a very fruitful discussion. And I thank all the audience who have been very patiently listening.